While in many ways, PDPM presents as a great challenge to our industry, but in many other ways, it's really an opportunity to focus on bringing value to clinical care. Michael Porter defines value in healthcare as outcome divided by cost. For the last 5 years, we've been quite purposeful in our movement toward value-based care. So let's think for a moment about what we can do to increase the value of the care we deliver. Let's look at the outcome part of that equation first. We generally measure outcome as the difference between an individual's status or performance at evaluation and discharge. That difference, that discharge value minus the evaluation value, is the outcome. And we measure outcome not only at the level of activity limitations, such as the CARE score or an FCM category, but also at the level of impairment, as reflected in gait speed or grip strength or a 6-minute walk test distance or a MASA score. This collection of outcome data at the individual patient level, which we've been able to aggregate and study, is central to our understanding of how to move forward in delivering consistently high-value care. We can increase value by increasing the outcome, giving a larger numerator in the value equation. Starting in 2017 and through all of 2018, we've been implementing standards of care. These standards of care are based on external best evidence and so far have largely been linked to the ideas of intensity or challenge and to that of patient activation or engagement. We've systematically been applying intensity interventions such as high-intensity resistance training or gait speed training. The entire purpose of these interventions is to maximize outcome, not only at a functional level, but improvement in the impairment level as well. This improvement at the impairment level is what we hypothesize is critical for protection against adverse events in older adults. The stuff, if you will, that patients need to protect them from functional decline or falls or hospitalization and so on. But it's not about intensity alone. And our clinical model of care also includes an emphasis on patient activation. The body of evidence related to the importance of patient engagement in their own care is significant. And the good news is that patient activation or engagement is a modifiable characteristic. That is, people can become more activated in their care. And we, as rehabilitation providers, can provide interventions to make that happen. We've started with OT, but look for these types of treatment methodologies for PT and speech in the next year. All of this is to say that we believe we can increase the value of the care we give our patients by maximizing their outcomes, and we can do that by systematically providing best evidence care. Really. We can also improve value by lowering cost. Now, often when it comes to cost control in healthcare, providers gravitate toward a blanket reduction in length of stay. We see that as a one-size-fits-all type of strategy, and based on the analysis of our own data, we know that one size does not fit all. We believe that the key to controlling cost is matching the amount of care we provide to each patient to their responsiveness to care. We know that not all patients respond to rehabilitation in the same way. First, are we delivering the right care? Recall my previous comments about maximizing outcome. Second, if we are delivering the right care, can we identify patients who are not responding and adjust our approach? Do we need to focus more or perhaps only on adaptive strategies and caregiver training with some of our patients? And if so, can we identify those individuals quickly and deliver that level of care efficiently and effectively? In this fashion, we accomplish what rehabilitation can accomplish in these cases, but at a lower cost, thereby increasing the value. The foundation of our clinical model is in place. PDPM provides us the opportunity to deliver a consistently high-value care experience to all of our patients by matching the care we provide with the patient's level of responsiveness. And we do that by truly practicing at the top of our license, by tweaking standardized care to meet individual patient needs, by engaging in assessments and reassessments with consistently high levels of clinical reasoning and decision-making, by owning the care we deliver and managing our cases with an eye toward value, maximizing outcome while controlling cost. PDPM, nothing to be afraid of. We're ready. We've got this.